Okay, good morning, everyone, and thanks for joining us again for Discussions in Diagnosis. I'm Goutham Rao. I'm the PI and Director of the UH Advanced Center. And this morning we have Dr. George Matar, who's one of our own third-year residents here in our family medicine residency program at University Hospitals, our primary residency program, as well as an interest in preventive medicine. And George is going to talk to us about a topic that is really timely, I believe, but also something that's quite different than some of the other topics we've had. We've been kind of all over the place on purpose, talking about cognitive errors and diagnosis and approaches to common problems. But we're here to talk to George about gender dysphoria. And I will confess, I know relatively little about it, and what I have learned has come from doctors Matar and Castor and just my own reading in journals such as American Family Physician. So George, welcome, and thanks for joining us this morning.
Thanks, Dr. Rao.
So I think to start off with, can you define gender dysphoria for us? I've seen some definitions online, but perhaps you can expand on those a bit.
Yeah, sure. So gender dysphoria is the psychological distress that a patient experiences that results from that incongruence between one's sex assigned at birth and one's gender identity. And a lot of times we see gender dysphoria beginning in childhood, but a lot of people may not experience it until after puberty or much later in life. And it's kind of important to note that gender identity is a bit different from gender expression. So these are some terms that I'll be throwing out a little bit here, whereas gender identity refers to one's psychological sense of their gender. Gender expression actually refers to the way in which one actually presents to the world in a gendered way. So that's just some terms that I think are important to note moving forward.
Okay, that's really helpful. So I would think that it would be very difficult to have any sort of epidemiology around this, just because it's hard to detect and may not be something that's disclosed very often. But how common do you believe it is?
Yeah, so many research outlets have actually tried to collect and quantify this data and get epi information like you've mentioned. But a lot of times this isn't a question commonly asked during a patient encounter, and patients don't self-report this either because they may not be comfortable bringing this to the attention of their provider, or they just don't feel that it's important to discuss this. So the DSM-5 actually estimates that roughly 1 in 10,000 assigned male at birth and 2 in 300,000 assigned female at birth individuals are actually diagnosable with gender dysphoria. Several studies have showed a greater frequency in certain countries. I was looking into it. Japan and Poland apparently have higher rates of diagnosis of gender dysphoria than other countries. But a lot of times we think that, there is a much higher number than we think because the ICD-10 code's not being used as frequently as it could be. Now, we do have recent data from the CDC's behavior risk factor surveillance survey that they collect, as well as the youth risk behavior survey. And that showed that about half, like 0.5% of all US adults, which is about 1.3 million people, and about 1.4% or 300,000 US youth in the ages of 13 and 17 actually identifies transgender or have a gender identity that's different than the sex that they were assigned at birth.
So that's a quite a significant number, either way you look at it. So can you kind of take us through the life cycle? And you started to hint at that a little bit, and puberty playing a major role, but at what age do we generally see this developing? And what are the signs and features that it is developing?
Sure. So the diagnosis of gender dysphoria can be at any age. And for those who experience gender dysphoria later in life, they often report having secretly hidden their gender dysphoric feelings from others when they were younger. And the signs and symptoms that these adults and adolescents experience are a marked difference between their gender identity and their assigned gender at birth. And this has to have lasted for at least 6 months to be properly diagnosed with gender dysphoria. So what are those differences? So I mentioned that there's a marked difference. So there's some criteria that goes into that. So One of the criteria you can meet is a difference between gender identity and genitals or secondary sex characteristics such as breast size, voice, facial hair, amongst other physical characteristics. And in young adolescents, that would be the difference between their gender identity and any anticipated secondary sex characteristics. Another point that could be different is the strong desire to be rid of genitals or secondary sex characteristics, or a desire to prevent the development of secondary sex characteristics, like we mentioned. Third would be a strong desire to have the genitals and secondary sex characteristics of another gender. Fourth would be the strong desire to be or to be treated as another gender. And fifth would be a strong belief of having the typical feelings and reactions of another gender. So again, you need 2 of these 5 points and have experienced these symptoms for at least 6 months before you can qualify and have that diagnosis of gender dysphoria. And although, this next part isn't really part of the criteria, but it's worth mentioning that gender dysphoria does cause significant distress for these patients and how they function in social situations, at work or school, and in other areas of life. And they may have low self-esteem, become withdrawn or socially isolated, have depression or anxiety, may be taking unnecessary risks, and ultimately neglecting themselves and their health.
Wow, that's fascinating stuff. So I will tell you, I've never personally encountered a patient presenting with gender dysphoria. And the few patients I have seen have been diagnosed by other people. But I'm curious, how is this coming to light in the clinical setting? Like, I mean, is it a question with a young adolescent who feels depressed and there's a detailed set of questions that come up? Or how are people making the diagnosis?
Yeah, so I mean, as a society in the field of medicine, we've been much more vigilant in promoting wellness, encouraging individuals to not only seek care for physical health, but for mental health as well. And as practitioners, we actually play a large role in bringing gender dysphoria to light, especially for patients who may still not be comfortable discussing their gender identity. So when a patient is establishing care with you, asking about preferred pronouns and gender identity is an important question to include in your history taking. For myself, it's naturally come into discussion when gathering a full sexual history, which usually takes place during the health maintenance visit, sometimes during an establishing care visit. Some patients may not know what pronouns are or what you mean by gender identity, but you'd actually be surprised as to how many patients will disclose their pronouns or how they identify, frequently saying that you're the first provider to ever inquire about this.
Wow.
And this is obviously important information to gather, because not only may we unmask a patient who has gender dysphoria, but we can also provide appropriate guidance, for example, with STD testing and prevention once we know a patient's preferred sexual practices. And I would say another way that it's come to light is through community referrals. We commonly get referrals from our community LGBTQ center. Community members may reach out to the center for guidance for LGBTQ-friendly providers in their area and refer to our services. This is due to collaboration that we may have with these centers, or it might be because the provider is actually proactive and may have their name listed on an LGBTQ provider directory, such as the GLMA, it was known as the Gay and Lesbian Medical Association, but now it's Health Professionals Advancing LGBTQ Equality. So patients can contact you through that directory or through referrals, or you can just bring it up during a patient encounter. There's many ways it comes to light.
So it comes to light in many different ways. Now, I was looking into what they do in the UK, and the NHS, interestingly, has a recommendation that if you believe that you or your child or someone you care about is experiencing gender dysphoria, the first place to go is your primary care physician, known as a GP. And immediately I thought, oh my gosh, if that starts happening here, we may all be in a tough situation. But let's consider situations. You and I have a shared connection that one of my friends, her son had gender dysphoria, as you know, and you've looked after him for some time now. But let's say, she comes in as a female and reports these consistent feelings to her parents. They reveal those feelings to you. She confirms them. What are the next steps? What questions would you ask at that point?
Sure. So every time I start a patient encounter, I try my best to introduce my preferred name and pronouns and ask the patients their preferred names and pronouns to make the patient and their loved ones in the room comfortable. And I then proceed with getting the patient's past medical history, which includes any psychiatric history as well. And once I have this information, I proceed with getting the gender story. I call it the gender story, which is, how they got to the point where they got to today, preferably from the patient themselves, hearing it from their point of view. Even if it's a minor, it's great to hear it from the patient. And this is helpful because it helps me gauge not only how long the patient has been going through these incongruent feelings about their gender, but what signs and symptoms kind of led them to this point. And in the conversation, I also gauge what their current support system is, whether it's their parents, school, community, workplace, friends, etc. And you can kind of gauge from speaking with the parents if they're actually supportive of, this gender identity that their child is expressing, or if they're not supportive of it. It's good to know if they've been seeing a counselor or falling with a mental health provider for this. Those records are really invaluable to understand the thought process of the child over the last 6 months or over, a longer period of time. And if we are referring to a minor in particular, that conversation can be difficult if the parents are not supportive of the child's diagnosis of gender dysphoria. So for these cases, we often have close collaboration with, a mental health professional, the child's school, or an LGBTQ specific counselor to really coordinate the best care possible until the child is of age and able to make their own medical decisions.
Sure.
And of course, if there's a suspicion for child abuse or, other issues like that, it's really important to involve Child Protective Services and, your social work team in your office.
So I get the impression this is not a one-time encounter. Here, my child believes he or she has got gender dysphoria. Okay, let's ask some questions. We're done. You're diagnosed. Let me refer you on and let's consider treatment. It's something that may evolve over time and may involve multiple visits. And I can imagine that, especially in a young adolescent, it takes some time to draw out this information. That's, I think, what the message I'm getting from you. Okay, so let's turn our attention to you mentioned how this often comes to light. It can come to light through taking a detailed history, inquiring about a sexual history, a psychological history, or through community organizations as well. Are there any circumstances, in which you would, for example, screen a patient for gender dysphoria? When I was a resident, 25 years ago or somewhat like that, we were always told, for example, not to approach sexuality, to approach it in a very objective way, and to ask, do you have sex with men, women, or both? And then that starts a very respectful way to start that conversation. But are there circumstances in which you would actually inquire about gender dysphoria when it's not something that the patient is presenting with or has concerns about?
Yeah, so I would say yes. And that's definitely something we should be doing, especially like I mentioned in those establishing care and health maintenance visits. And, I actually have had a situation where I had a young male assigned at birth, came to establish care with me and had a past medical history of hypertension. They asked me during the encounter, just openly, that they wanted me to call them a more gender neutral name. Which was a bit of like a questioning thing for me as well. So after that, I proceeded to state my pronouns, asked the patient if they had any preferred pronouns. They told me they went by they, them, and that they identified as non-binary. And they really did appreciate the fact that I acknowledged their preferred name and pronouns and, the way they expressed their gender. And I carried on, to talk about their hypertension, et cetera. Then when I brought them back for an additional visit, for their health maintenance visit. And at that visit, I started talking about their sexual history. And like you mentioned, we've kind of progressed a little bit in terms of asking about sexual partners and such. So, you may say, do you have sex with, men, women, transgender individuals, or any other gender? I kind of open it up a little bit more. And then I also kind of go even further to say, are they cisgender individuals or are they transgender individuals? Because many patients will refer to their partners as male or female, but they may be referring to a transgender female partner or a transgender male partner. And this is obviously important to know because, it's good to know what types of sexual practices our patients are having. Through that health maintenance visit, I did discover that there was some component of gender dysphoria. And then again, I brought them in for a third visit, to actually discuss that even further. So you're right, it's a process. So overall, it's, it can't be achieved in a single visit. we do need to have several visits to kind of get this clarified and to honestly establish rapport with the patient. That's something important because this is a very private, confidential information to them. So it's good to establish that rapport.
Yeah, and I think it's important to keep in mind that patients who are experiencing gender dysphoria they also have asthma, they also have hypertension, they also need to quit smoking if that's an issue for them as well. So I want to talk near the end now about what we can do as health systems, because you're clearly very sensitive to this issue. You have a special interest, and thank you for helping to lead this along with Dr. Castor within our department. But broadly, what can we do? We've done some education events around this to raise sensitivity. But in terms of how we deliver healthcare, what are your thoughts about that?
Yeah, so I mean, it's important to know, we were touching on this a little bit, that the transgender and gender diverse population are really a very at-risk population in the US, and they have less healthcare coverage. They face significant socioeconomic barriers in housing, education, mental health, and all of these issues, only get worse when we talk about trans people of color. So because of these adverse social determinants of health, trans people actually have these serious health conditions, don't follow up for hypertension, don't follow up for asthma, diabetes, et cetera. So, establishing that rapport, like I mentioned, is really important, and building on, these top three things: conveying respect by utilizing appropriate LGBTQ terminology, identifying what are the best practices for interacting with transgender and gender diverse patients, and ultimately implementing strategies for fostering this cross-cultural care. And some ways, examples that we can do this, some of them we do in our clinic currently. So we ask for preferred names and pronouns and documenting this accordingly in the EMR. And while we often don't really think twice about assuming people's pronouns based on their physical appearance, it's really important to recognize that pronouns don't always parallel an individual's appearance or gender identity. And misgendering or using someone's incorrect pronouns can actually be harmful, even if it was unintentional. And another thing we can do as a health system is really to create a welcoming environment. So simple gestures like signs of affirmation and acceptance, like a pronoun pin on your badge or a rainbow sticker, or magazines and pamphlets that represent the patient population, go a long way. And honestly, I've had conversations regarding gender care start with my patients just through a conversation about my badge or my, the sticker, the pins, and that really does open up that discussion and makes the patient more comfortable to discuss that. Another thing that you could do is designing paperwork to be more inclusive in the clinic. So including a space for chosen names, sexual orientation, gender identity, that makes patients more comfortable. Another important thing to note is where to refer a patient for more resources. So like you mentioned, I mean, it's okay to not be super knowledgeable on the topic of gender dysphoria, but knowing which providers or resources are available in your community is a really valuable resources for you and the patient. So knowing who can you turn to for help or guidance in terms of, getting this patient the care they need. And it's really important to keep in mind, though, that the gender journey of every patient is really unique. And although some people who identify as transgender or gender diverse desire to medically transition, not all do. So it's really important as healthcare providers to not assume that what someone's journey might look like, but be aware of the services offered to patients. So, and then lastly, which I think is the most important thing, is, continuously expanding you and your staff's competency is really key. So being able to have staff trained on a routine basis in providing gender inclusive care, not only in a primary care office, but really as a hospital-wide initiative, would really allow gender diverse individuals to feel welcomed regardless of what specialty they may be seeking care from.
Right. Thank you, George. So you mentioned something that struck me, and that this is, for lack of a better term, a marginalized population.
Mm-hmm.
Can you talk to us a little bit, because our department has a strong commitment to marginalized populations across the spectrum, as does our institution.
Mm-hmm.
But can you talk a little bit about perhaps some of the economic circumstances, the social circumstances in which these individuals live?
Yeah, absolutely. So a lot of these patients, they may have access to resources, but just don't know where to go to get them. In addition, they feel unsafe going out into the community and seeking these resources due to retaliation they may face from other individuals. So a lot of times they will actually stay within their social groups and may not get the care they need. we do know there's a large population of transgender individuals that do complete suicide, a lot of that because of mental health concerns. And another issue is really being able to guide them to know what is the care that they actually need. So if they don't come to their physician's offices and don't get that information, that's kind of the point where right now where we're really struggling is actually getting them to come to the office to provide them, either with social work services or finding out what are the economic struggles they may be facing. A lot of them are sex workers and don't have jobs, like actual legitimate jobs. So there's a lot of concerns that go about this when there really shouldn't be, and we can provide that information for them if we can actually get them to come and see us. So that's why those community resources are crucial.
Great. Thank you, George. So I'm going to open this up to any questions or comments from our attendees this morning. So please go ahead. There is something in the chat from Elizabeth Harris. Thank you for speaking about this topic. We see these patients quite often in psychiatry, but we know everyone doesn't make it to specialized care. Your work in primary care is very important. It's equally important to ensure everyone is aligned with the patient's needs. How do you engage families when they are less educated in this area? Yeah, that was something that I think kind of stuck in the back of my mind. If you have family members who are not supportive, in other words, the child is expressing, they've come in for some other reason, the child is expressing gender dysphoria, and it's clear the mother, father, or both are not congruent with that idea. Don't believe it's true, or even if they believe it's true, think that this is something that ought to change. Well, what do you do under those circumstances?
Yeah, so when we have a patient that's dealing with that situation, family counseling is actually one of the best ways to go about this. Of course, you would need to get the parents and the child agreeable to a family counseling situation, but having an understanding of where each party is coming from does help the parents better understand what their child may be going through.
Mm-hmm.
In addition, you can have individual encounters with both the patients, the parents, and the patients, and kind of see, have that individualized discussion with them and kind of figure out, engage what are the conflicts with this situation, what are the hesitations with their child having, this gender incongruence. So these are some things that you may want to discuss in a setting where it's just the parents or just the child, and then ultimately have them all together and kind of have this group discussion.
Okay, thank you, George. Any additional comments or questions? I'm going to scroll through.
I think one of the most important things that I'm getting from you, George, is that it's the key is that patients have a place where they can feel safe and understood. I think that as time goes on, society in general is becoming more aware and more accepting, but even still, there's so many emotional, it's kind of an emotional minefield for a lot of people, and, for people who don't understand gender dysphoria. And it's just really important that people have a place where they can feel safe.
Thank you, Julie. Any additional comments or questions for George before we wrap up?
Yeah, this is Mary. I just want to say
Mary,
thank you so much. Yeah, thank you so much, George, for this great topic. And I think your point about the culture change, like systematically or in the system, is really key. And I think it goes back to, the whole what matters question that we have, like an age friendly for older people, that, people, want to be heard, and just doing what matters to them is like a key. So, thank you for this session. I really enjoyed it.
You're welcome.
Thank you, George. I think we could start with a basic principle. I used to live in Wilmette, Illinois a few years ago, and it's the headquarters of the Baha'i faith, and there's a giant Baha'i temple there. And outside, there's a huge sign that says, "All are welcome," period. No exceptions whatsoever. And I think that's a good starting point for us. And I think doing some of the outreach to the communities that you spoke about is very, very important as well. Thanks for a fascinating discussion. Thanks everyone for joining us this morning, and have a wonderful day and a wonderful weekend. Take care.
You too. Thanks.